Right, welcome everybody. No apologies. I think everyone is here. Any declarations of interest? Nope. Everyone happy with the minutes of the last meeting? Right. Should we go straight into your report, please, David?
Good morning, everybody. This is a report which has 14 items on. All are updates, so I'm going to do this very, very quickly, David. There's no new announcements. The significant item, I think, is the one about PERDA and where we are in relation to PERDA, but I'll speed through what's effectively a progress report. So in paragraphs 1 and 2, I'm updating you on issues to do with staffing. That's progress in relation to recruitment, which continues to be good, with over 230 now offers made to inspectors against the objective we've got of getting 300 by the end of April this year. The figures on the operation of the academy are set out on page 2 and in paragraph 2, and you can see the progress that the academy's made in actually making these offers, and then in the progress that are made of inspectors going through training in the new regulations and the new methodologies as we roll those out. As is usual in this report now, there's updates from each of my 3 senior colleagues, Mike, Andrea and Steve, in relation to the progress that they're making in relation to inspections. And as you can see, the new methodology now being rolled out pretty comprehensively, and good progress being made. And I'll not highlight any of those. In paragraph 6, you previously, as a board, asked for an update on our work on child and adolescent mental health. And one of Mike's clinical fellows has undertaken some analysis of our inspections to date, and that work is set out in paragraph 6. You are, over lunch, colleagues, going to meet 8 of our senior colleagues from mental health services, Paul Elliott, some of the policy people, some of the people undertaking the Inspection and Mental Health Act Commission work. So you may want the opportunity to discuss with them over lunch some of the issues there about how the new approach in mental health is taking place and taking a grip on what we do. I previously mentioned a meeting with David Norgrove at the Low Pay Commission, and that meeting took place last week, and we do think there's an opportunity to look at how we might collaborate with the Low Pay Commission, particularly around sharing joint intelligence or undertaking some joint research with them, and we'll pursue that further. We are doing some joint work with... Sorry.
Yeah.
Sorry, Camilla.
I just wonder if you could say a bit more about that, David. Where you think we can add value to that?
So there's previously been a debate about 15-minute visits, and when providers have actually explained why that is taking place, they've explained that that's down to the way that they're being commissioned for services. Clearly, there's an issue about whether 15-minute visits impact on the quality of care that people are offered and the way that that's offered. And so we followed up conversations with HMRC and with the Low Pay Commission in relation to what the opportunities were. I've also been meeting the provider trade associations, and UKHCA, who are the trade body for domiciliary care, have raised the issue, not just with us but with others, that some authorities are commissioning domiciliary care at a contract price of £11, £12, £13 an hour. They would argue that in order to pay the national minimum wage to staff, then those contract prices need to be closer to £15 to £16 an hour. To pay a living wage, it needs to be between £18 and £21 an hour. And so the issue really is, how does the commissioning impact on the quality of care? And I think we need to have a position on that. We need to understand what that relationship is. So any joint work might help us to better understand what that relationship is between the way that services are commissioned and the quality of care. So these are exploratory discussions. There's been no conclusions, Camilla, but we thought there was merit in having a further discussion about whether there were opportunities. We don't know until we've concluded those discussions, but we thought there was merit in having further conversation.
I would really welcome that, and we had a brief chat with David Pearson about that last night, who's also talked to HMSRC, and I think to get everybody in the room, because this is an issue that's been ongoing for so long, it just needs to be solved, it seems to me. But I mean, I suppose the question for us will become how political we're prepared to get. Because there's, the way David Pearson put it last night, which I thought was rather interesting, was it's not just the local authorities and the care providers, it's also a question about funding and government. So as long as those three things are in the mix, I think it would be great for us to be involved in it.
Yeah, he made the point there should be three people in the mix. It's local government, it's us, and it's central government. It's funding as well as commissioning.
And CCGs, because they're commissioning, etc. So we'll get a big room. National Information Board is looking at how all of us that are using information are coming together. Paul is largely leading this work, but this is a board that's been doing some interesting work in bringing together health and care bodies to actually look at work. And I've been asked and agreed to co-chair with Simon Stevens some work on this, which we've set out. In reality, it's Paul that's taking this forward. On PERDA, what we've attempted to do in these paragraphs is just set out what the traditional approach is to PERDA by public bodies. I think the key issue here is what is our normal business? And our normal business is publishing the reports of the inspections that we've undertaken. So the inspections that where the reports will be published during the period from the 30th of March to when the election takes place at the beginning of May. Those inspections have now taken place, so we know exactly what reports we've got to publish. And we have a programme to publish those. Obviously, this depends on things like factual accuracy and whether people request a review for the final date for publication. I've also written to the Cabinet Office setting out what that programme is and named the inspections that have taken place and the projected dates for publication. I wouldn't mind just clarifying one point in this bit of the report, David, and that's, as I understand it, when Parliament does prorogue on the 30th of March, MPs become prospective parliamentary candidates unless Parliament's recalled for any reason. So I think we've, I think the use of my language in this, where it's saying we, when Parliament has ended, we'll write to MPs. Well, they aren't MPs in that sense. They are prospective parliamentary candidates, and they'll get the reports like any other member of the public will get a report when we publish it. The other reports that we publish, we're not planning to publish any thematic reviews or any similar kind of major statutory reports during that period. So I hope that provides some clarity for colleagues around this board table in relation to the approach that we'll take during PERDA. The letter went off to the Cabinet Office and DH on Monday, I think it was. In 10 and 11, I just want to draw attention to the fact that Robert published his report, Freedom to Speak Up, on the 11th of February. And on the same day, the government published their report on hard truths 1 year on, slightly longer than 1 year on. And the progress that we have made over that period was reported in Hard Truths 1 year on, and on page 8 I've set out some of the key points, not in an exhaustive way, but just to give some illustration. Kate Lampard was the person that the Secretary of State asked to draw together the learning from the 3 agency reports that were carried out on Jimmy Savile's involvement at Leeds General Infirmary, Stoke Mandeville and Broadmoor Hospital. She has now completed her work, and that report is due to be published tomorrow. There will be recommendations in her report for changes that need to be made at a local level in relation to a number of the lessons that she's flagging. There will be implications for CQC in terms of our inspection to check that those changes that she is recommending are made are indeed followed through. The bulk of the recommendations are for trusts and monitoring the TDA. We previously reported on the Morecambe Bay investigation. This is an investigation into maternity services, and we now have a date for that report being published. That will be published on the 3rd of March. The time we drafted this paragraph, we didn't have a date for that. We've had a number of staff, past and present, who have given evidence to the investigation, and it is likely that they will be named in the report, and therefore we'll offer support to those individuals, and indeed letters will go out to them today outlining what that support is. This isn't a report about regulation at Morecambe Bay. It is a report about the provision of maternity care. However, given what we've publicly said in relation to our oversight of Morecambe Bay in the past, one can anticipate that being repeated. So, as I say, it is ostensibly a report about the delivery of maternity services, but our part in the regulatory oversight of Morecambe Bay is now a matter of public record, and it may well be that that's touched on. As I said, the date for that is the 3rd. Another historic investigation has been commissioned by the Minister for Care Services, Norman Lamb, and this surrounds the care that older people received at Gosport Memorial Hospital. This goes back to the late 70s, so this really does go back quite a long way and predates any of our predecessor bodies, to be absolutely frank. But we've got probably 300 records of our predecessor bodies as they relate to Gosport Memorial Hospital. So we'll assist that panel by making those records available to them. And I think that panel then begins. It's the Bishop Jones who actually chaired the Hillsborough inquiry, who will actually lead that panel. And then lastly, David, I'm just identifying for the board that we've now published these 3 documents on enforcement, Memorandum of Understanding on Health and Safety, and the information leaflet on surveillance, which at long last. Thanks to Lewis for just getting that over the line at the end. So that's the report. Thanks.
Okay. I'd just like to go back to the Freedom to Speak Up review. Can you just clarify what the next steps are for us? Because I understand there's going to be a consultation. So do we need to respond to the consultation, or do we contribute to the consultation? And because there's sort of dynamics as to what we influence and when.
No, very good. Sorry, and I probably should have said that in fairness to Robert as well. So the government have received Robert's report, accepted the recommendations in principle, and said they will consult on it. That consultation, I understand, is going to be short and intense and needs to be concluded before Parliament prorogues and Parliament ends. So effectively, they're looking at a 3 to 4 week consultation during March, and they will need to ask the question about how the National Guardian, what arrangements are made for that. Then need to conclude that, and if the government are to determine that that is to come to us, then we will make those arrangements. What I've asked is the colleagues that we've had working on exactly these issues continue to do that work in terms of scoping what we think this role is, etc., etc. So that work will go on alongside the consultation if it is to come to us. So it is a formal consultation that the government will undertake, and as a result of that consultation, they'll then have to make a decision about what, not in principle, but in detail, of those recommendations they're going to accept. So that's, as I understand it, where we're up to.
Yeah, I actually had a chat to Caroline Fawcett yesterday, who, as colleague knows, is the CQC, leads the CQC's work on concerns. And we did discuss that it was important for the CQC to appoint its own speak-up guardian as soon as it was feasible. And she said that there were plans in place for that to happen, which sounded very encouraging. Also, just one other point, because David mentioned it. The government's one-year-on report said about the CQC, it was the toughest inspection regime in the world, was its precise words about the CQC.
Just say, the consultation, as I understand it, is to be short and intense, and therefore I assume is underway at the moment. But although normally one would expect there to be a consultation document, and I've not actually seen one. I don't know if anyone else has, but I just mentioned that point. But the other point is that the Secretary of State did make it clear in his acceptance in principle of the recommendations that there was much in the report that NHS organisations could get on with now, and I'm encouraged to hear that we are ourselves getting on, as it were, with appointing our own guardian. And the other point, which is in one sense peripheral to our interest, but they also have said that they intend, with cross-party support, to change the law on discrimination this Parliament, which is a big ask, I would have thought, but that's what they intend to do. I just thought that it would be worth saying that, but I welcome our own organisation's commitment to this.
Let's ask Robert, how many local guardians are there actually around the country now, do you think?
Well, I only know of two that are who undertake posts that could be loosely described in this way. There may well be other organisations that have arrangements that have equivalents to that. Many trusts, if not all, have an independent director to whom people can go, but obviously this is one step further than that.
Dave, thanks. Can I say that I actually have a couple of questions for the inspectors, and I've got slight concern that the truncated way that we do the report, your report, David, although I understand that there's pressure on time, means that we are slightly restricting inadvertently the time that's available to ask questions directly to inspectors. We just need to make sure that has enough prominence in how we feed back to the board. Before I ask those questions, can I just ask there's a sort of two-part question about recent reports or recent announcements about reports. One is the Equalities and Human Rights Commission report this week, which was about deaths in custody, mainly about people with mental health problems who died in one form of custody or another, but including, and in particular, people who died while detained under the Mental Health Act. The principal recommendation of that report was that there should be a new system for investigating deaths of detained patients. And I just wanted to make sure that that we are responding to that, and that whatever process now follows that report, that we're part of it. The second thing, I'm sorry, it's completely unconnected. Well, it's not completely, it's largely unconnected, is that the government's announced a review into Yarlswood Immigration Removal Centre, which is going to be headed, I think, by a former prison ombudsman. And so this is probably through to Steve about our possible involvement, because a lot of the issues at Yarlswood are actually about health, and in particular about mental health. Although some of them have, in the last year, have been about access to non-mental health medications, such as medication for asthma. Yarlswood has caused concern for the Children's Commissioner and for others. The UN is on the list of people who've been concerned about it. Some charities about supporting women refugees. And a lot of that concern is about mental health. And so I just wanted to make sure that in this review that we have a place there. perhaps I could stop there for a moment.
So on the EHRC report, yes, we have been involved in that from day one on the commission of that. In fact, when they had the idea to commission a report into this area, they discussed it with us, and a member of Paul's staff has tracked this through all the way to the end. We saw the draft report before it was published and have gone through that. So I think there's been good and close collaboration between EHRC and we have an ongoing relationship with the EHRC. The next stage of that is I thought they were making that recommendation to MOJ in relation to it, and of course what you've now got are reports making recommendations to a government that was literally is within days of ending. So I think it's down to the government to respond to the EHRC report and how they're going to take it forward, but we will work with EHRC. I think we've had a very constructive relationship with them throughout this, and we intend to continue with that relationship, not just at a senior level, chief exec to chief exec, but in terms of the people that have actually physically worked on this report. I feel we've been very cited on it, and it's been a very constructive piece of work. And of course it is something that sits in a complementary way to the work that we do in relation to this issue, as you know from other roles that you've had, Lewis, around just how important this issue about who is looking at deaths in custody and how those lessons needs to be learned. And I think it does have a bearing on the work that we do, but this is one way that we can ensure it does. But I think the follow-on, the next stage, how this is taken forward, is as much for MOJ and other colleagues in government as it is about us, because if anybody's going to set up a new body, it's got to be government that does that.
Well, it's a similar answer in a way, and we have an ongoing relationship with the with our colleagues in the Inspectorate for Prisons and Probation, and Sue McMillan, my deputy, leads on that. And what I'll do is I'll give you a note of where we are at the moment with it. I don't know the detail today.
Sorry, I don't want to hog this too much, but this is my point about being able to ask questions to each inspector. So I do have additional questions. So one of the items in the review has been about CAMS. Another one is about the first mental health trust to go into special measures, or to be recommended, I should say, for special measures. And there is a common element to what's being said about in both of those items, and that is about staffing levels making the service unsafe. So I just wanted to get the from you, Mike, if you have the detail, how the staffing at this particular trust was bad enough to make it the first mental health trust to be recommended for special measures, given that that this issue of staffing is something that's complained about across the mental health world at the moment. And then there's a point about whether there are some messages we could get out about what will happen if staffing doesn't improve. Because if all mental health trusts are going to find that because of the way they are commissioned, because they have to live within their budgets, that they are going to end up with poor CQC ratings, whether it's special measures or not, then that needs to get out. That is a factor which is determining the ratings of a number of services. If you take the example of Norfolk and Suffolk, the trust that's been recommended for special measures, presumably it's going to increase its staffing levels. It's going to have to spend some money. I just need to slightly understand where that money we envisage that money might come from, which will help them get out of special measures. And then on this issue of CAMS, it's a little. What we're saying is a little bit vague. We said there are some issues. Some trusts have problems in inpatient services. I just would be useful to know what issues, how many trusts.
Okay, if I start with Norfolk and Suffolk, I think what we're doing here is to apply exactly the same approach to mental health trusts as we do to acute trusts. And as you will know, we have commented in a number of individual core services within individual acute trusts that staffing levels are not sufficient to give safe care. And Yes, I think that has resulted in people having to recruit more staff, and most of them may have been in the process of recruiting more staff anyway at the time. And where that was the case, we've said so because that reflects on the well-led domain. I think we just have to say it as it is, and where we find that there is staffing that levels that are inadequate to provide safe care, we say so. We have looked back through, I think, the first 10 mental health trusts that we have inspected and really specifically gone through them to look at the issue of staffing. And it's a very skewed distribution, interestingly. There are 2 or 3 where staffing is a major problem, but that has not been necessarily the problem across all 10. And I can share with you, or you can talk to Mark Generate, who's the clinical fellow that's been back through them to understand that in more detail. But it is not the case that every single mental health trust is the same. We are saying that this was obviously way out, and which is why we recommended special measures. But it's a different picture, and which is why we need to inspect each one of them to see what the picture is. So I think that's on staffing generally in mental health. In terms of the CAMS position, again, it was the same clinical fellow who did the analysis, and I think the ratings are only based on 4 trusts, and one we provided separate ratings for the community and for the inpatient CAM service. So I think the ratings are very early stage. I think in general, once you've got into a CAM service, the CAM services are performing reasonably well. The problem, and we refer to it under the responsive domain, services were not always configured to respond fully to the needs of young people, and the lack of specialised CAMS provision out of hours, or the lack or specific CAMS crisis teams, was commented on in several reports. So I think we are pointing to deficiencies here, but that's deficiencies that are sometimes not actually within the service that we are inspecting. But I think that is useful to have looked at, because I think it will also inform how we inspect in the future.
I think we've got Paul Elliott who's joining us at lunchtime with his team, so I think we can probably pursue that if you wish to then.
Okay. My point about generic or general messages and how we get them out before we get to the point of putting trust into special measures. I think you're absolutely right, Mike. I completely support the fact that we've got to tell it like it is. But at the same time, if that's how trusts are falling down, then that would be quite a good message to get out before we even turn up, I think.
Yes, I think we are getting to the point where we've done enough mental health inspections to be able to start providing some early overviews, and I think that's really where we've got to. You remember that with acute trust, where obviously the numbers are larger, we've already done that, and we published a report on the first wave of 18, and we've given subsequent updates on what the general position is. I think we're getting to that same point with mental health, where we can start saying, here are some general themes that are emerging from our inspections.
I wonder if I might ask about our approach in inspections to a finding that we have that the organisation has inadequate staff as being a reason for whatever the problem is. I mean, it seems to me that inadequacies in staff can be because of bad organisation in the organisation itself, or because genuinely there's a commissioning deficiency. Do we express an opinion on that, or do we consider that's not our role?
A classic case of that was one mental health trust where there was no psychiatric intensive care unit, and the mental health trust covered a very large county. And so it wasn't necessarily the fault of the mental health trust that they hadn't got a psychiatric intensive care unit, but nonetheless we felt the need to comment on the fact that that service was not there, because it meant from a patient perspective people were having to travel possibly hundreds of miles to get appropriate care, and that of course then does come out at the Quality Summit, and the commissioners are there at the Quality Summit, both in the form of NHS England and the CCGs. So I think it is our opportunity to say, look, this service is just not available, and this is what the impact is being.
But I mean, David, this is why I'm saying we have to have more time to talk to ask questions to the inspectors. They are the representatives of our organisation in the field, and this is a crucial part of what the board should be doing. So I will be quick, but we've got to ask questions. So Andrea, in your section, you said something very, very interesting, which is about the analysis of this is under item 3. The analysis following the closure of Merrock Park. After that, there was significant enforcement action against 2 other homes owned by the same provider. Now, at what point do we see a particular problem with that provider and take further action about that provider? Could you just clarify for me how that proceeds from here? If there are 3 homes from one provider which have required enforcement action, one of which has been closure.
All 3 of them now are not operating in terms of taking and caring for people. So there's been a complete change in that. But one of the issues that we want to look at in our review is how we made the connections between all 3 of those services and shared intelligence between the various teams, because it covered different teams in different regions. What we are doing in other circumstances, and we've had another issue with a very similar setup elsewhere in the country, where there was a provider where we had particular concerns that had been raised with us in investigating our knowledge and information about that provider. We kind of identified that one of the owners was kind of present in various other services. Sometimes the setups are actually quite complex in terms of following some of that through. And so what we did there was to share the information with all of the inspectors who had that provider, those locations on their portfolio, to highlight the specific concerns that we'd had and to ask them to review the position in relation to that to determine whether we were already going in and already taking action, whether we needed to go in, whether there were other concerns that this added to, and to look at action in terms of bringing forward inspections. So that's to give you a more generic kind of example of the sorts of things that we would be trying to do when we identify a cause of concern when somebody is running more than 1 or 2 places.
Just so I've understood that. So I can understand we might say, well, all other inspectors should be alert to what this provider is providing elsewhere. But at what point does it stack up enough that a provider has had so many strikes that they are in some sense out?
So we rate and inspect on the basis of location, and so the action and the regulatory kind of role that we have is in relation to the individual service. What we don't have either with smaller providers or indeed the larger corporate providers is the ability to go to the kind of overarching organisation, because sometimes there are different things that are affecting. We had another example last year where we had very particular concerns about a service, and it was actually the only nursing home service that this provider was running. And what was evident was that actually they were fine if they were managing residential care and they had the right structures in place for that. But as they got into the more complex areas and nursing home services, that's where we had concerns. And so we took action to restrict the ability for that provider to provide nursing home care. So we'll take proportionate action in relationship to what's required. The 2 other things that I would say is that in the future, obviously, we'll have the fit and proper person requirement, and that will come in for all of the other providers that we're regulating as of the 1st of April. So that's one of the things that we're looking at now, is how we would judge that on registration. And clearly previous history will be part of our expectation that organisations would have taken that into account. If people raise concerns with us, we would follow that up if it's a pre-existing service come the 1st of April. And the second thing is that we are wanting to do some work over the next year through the corporate provider team and working with policy colleagues in Paul's department to look at how can we get a better sense of what's happening in corporate providers so that we can use that intelligence better to inform our inspectors across the board. You know, bearing in mind that we don't have the regulatory power to go and get kind of information from corporate head office. So we need to be working that through with providers as to how we did that. But actually very many of them are welcoming of it because they see us going and looking at 15 complaints policies, which might be exactly the same complaints policy, whereas what we probably could do is look at the complaints policy once, say, yes, that's fit for purpose, but is it being implemented appropriately at a local level? So there is more work to be done on that.
David, we're now getting sufficient numbers out from each inspectorate to get a picture of each section of the health and social care, and they're different. And it seems to me in a couple of months' time, we could probably do with a discussion around that when there'll be a couple more months of numbers, because there is a divergence appearing between the outcomes, and we need to have a discussion about what that means.
Yeah, I mean, that's very clear. I mean, for example, in hospitals, there are far more that requires improvement, whereas there are far many good ones in adult social care, for example. Is that what you mean? Yeah. Yeah. Can we bring that back in, say, 2 months' time? Paul, do you think 2 months? We'll have enough information there, won't we? Yeah, we do that. Thanks. Right. Next item is the quarterly performance report. I think it's worth just prefacing it by saying that Michael Meyer, Paul Rue, myself, and David had a look through this a few days ago, and I think we're all agreed that for next year there's too much information in it, really, to really be able to look at it really intelligently. So what we're going to try and do is split out what we need on a monthly basis, what we need on a quarterly basis, what we need on a sort of a more on ad hoc basis, or on a once a year basis. So it is a little bit too busy, this. But David, would you like to pull out the main things you want to draw our attention to?
Thanks, David. And I think some of the questions that Lewis has been pursuing can actually be asked on the back of a performance report as well. And I think, Paul, to your point, I think there are tables in here which effectively they're not produced as a standard distribution graph, but effectively give that distribution and flag up those differences. So within that context, David, that the business plan will set out some of the changes that we'd like to make to this report in the context that you've just outlined. What you've got here is a report on the third quarter of the year 14-15. It flags the progress that we've made and the good progress we've made, I have to say, in terms of rolling out the new inspection methodology, and begins to project where we'll be towards the end of this current financial year in relation to the activity that we are undertaking, and they're set out in paragraphs 2. And I'll not present those in any detail. I wouldn't mind, though, drawing your attention to slide 28 in the pack, which is showing the trajectories. Again, I hope this isn't too busy, but I think you'll get a sense from the graphs here, more so probably than the words in the report, of where we are in terms of what we set out to do, what we revised in July we were going to do, and the progress that we've made in relation to our activity. So just to emphasise, one of the reasons for the shape of these graphs is twofold, really. One is the recruitment of inspectors, but more than that is the amount of activity that we've had to undertake in relation to following up on concerns, safeguarding alerts and whistleblowing that referrals that come through to the organisation. They are all need to be dealt with and do take time. And what we've found is that work is being accommodated alongside the inspections, and that in part explains the trajectories that you've got there. The three issues that I flag in the report, and colleagues that have had the oversight of producing this report are flagging, is our continued work on safeguarding. Are we recording the action that we are taking? And we are not doing that adequately. There's a number of reasons why that is the case, and as a consequence of discussions in the executive team this week on our progress in relation to this, I will convene a meeting and chair a meeting so we can actually bottom this once and for all in relation to what action we need to take in relation to our policy, what action we need to take in relation to the way that we record and account, and once we've got our clarity on policy and accounting, what discipline we need for every member of staff to make sure that that policy and process is actually being followed. I think all three of those are contributing at the minute to the performance that we've got here. In relation to the publication of reports, there are delays against our timescales for the production of reports, and they're set out on page 29 of the report. The consequence of this is that where we've got concerns in relation to a particular service, whatever that service is, any delay in publishing the report means that that's a delay in that going into the public domain. And if people are selecting services and reports are delayed, then it means that potentially people are selecting services without the most up-to-date information. And that's the issue about why this is important, and we need to make some progress on this. The report also on pages 37 to 43 touch on our financial position and the underspends that we're projecting towards the end of the year do reflect the point that I made in relation to our recruitment and, of staff. Any money that we don't spend will be returned to the Department of Health. It's unclaimed grant in that sense and will be returned to the Department of Health. There's also underspends on the capital programme, and the work to bring to conclusion capital projects is underway. So that is a position that is likely to change towards the end of the financial year. But I think it's highly unlikely that we'll commit all of our capital programme budgets for this particular year. The strategic risk register is also contained here. There was last week a meeting of the Audit and Corporate Governance Committee that went through this in some detail, so some colleagues around the board have actually been through that recently. But overall, it's a report which continues to demonstrate that we are making considerable progress in rolling out the new inspections and progress in recruiting staff and in developing our staff. And there are areas for development, particularly in relation to safeguarding and the publication of our reports, that we're flagging that the executive team are taking their time and attention to ensure that we are improving our performance, and we'll continue to pay attention to those areas as we go through the next few weeks and indeed into next year. I think your point, David, is that we need to look at this. There's a massive detail here, and we're in danger of losing the urgent amongst the massive detail. And so I think you'd asked with Michael and Paul that we actually bring a monthly report to our board meeting. We can do that because we take a monthly report to the executive team, so we can actually just bring that forward, and we can cull some of this detail from the monthly reports and provide some of it in the quarterly reports, and we'll have some conversation with board members about what you would like to see staying and what you would like to see going. That's different. What we report is different from what we need to collect. So it may well be that you've got questions that, because we collect it, we can answer those questions. We're just not going to report it. So we're actually producing volumes of stuff which is just too busy and you're not actually getting to. So if I leave it there.
Okay, thanks, David.
Thanks. Okay, so if it's a very interesting report. It's very good. I don't want to see us lose the too much because it's a very good account of where we get to. But I take your point that there's quite a lot of information, and maybe there are some broader strategic issues that come out of it, and they probably come out each time, which we need to have a particular forum for discussing. So with that in mind, I won't necessarily look for an answer to what I'm going to ask you, but just to say that these are two questions that I think that this report raises. One is, I mean, Paul is right about there is apparently an inconsistency, we don't know why, between the distribution of ratings in different settings. So the FARMOR requires improvement in the hospital sector. But it is more than that. It is also that there is a reason for that, and the reason is that they are being rated, getting low ratings for safety. So that if you look at the acute trusts, the hospital services, I suppose I should say. Mike, it's 10, I think, of, what's that total number? It looks like it's about 15% altogether, which get as high as good on safety. So the rest of them are, so that's over 80% are getting less than good. And that as an issue, I think, putting aside the detail of the figure, that issue is a concern. It's a little bit surprising it's different there from the others, but there is also this issue about what does that mean? Are we setting a rigorous standard which is unfair? I think that's unlikely. Or are we identifying, again, it's this idea of something that's endemic in the system rather than just relating to individual trusts. And my second point is about the overall link between intelligent monitoring and inspection outcomes, which is very interesting, actually. What it should, so this is what's on page 16. It's very interesting because what it shows is that if you're in one of the risk bands, so to speak, the higher risk bands, it's quite likely that you will get a less than good outcome at inspection. So that the prediction that's attached to being in one of the less favourable bands is good. So that's the good news. And maybe that's important for our public presentations so that when people are in those bands, we can say, yes, but that does actually, it's not completely unfair. It does turn out that that's quite a good predictor of where you will end up. As long as, of course, they're not self-fulfilling. That's the one thing. But the second not so good thing is that if you are in one of the more reassuring bands, you're still quite likely to get requires improvement or inadequate. In fact, the great majority of people who we give a good banding to are getting a poor rating, and that's because so many people are getting a poor rating. But the sort of statistical meaning of that is that our sensitivity is poor, so we're not picking up as a concern those that turn out to be concern on inspection. And so we've got too many false negatives, negative in the sense that they're screening as being okay but turning out not to be okay. And bear in mind that when we set out looking at this, that was our biggest concern, that false negatives would be too high. And actually there are too many false negatives. So there are some good things about where we've got to with this, but there is quite a concerning thing here, that our banding is reassuring us falsely about quite a lot of trusts.
Paul, can you address the second part of the second issue that Louis brought up there? Because I know you're going to bring back a detailed paper to the board about this correlation between intelligent monitoring and inspections, aren't you, at a later date? We'll do that. But just tell us where you've got to on that.
Yes, happy to. And just very briefly on the first point, one of the reasons why we will see more requires improvement in a big trust is because of the way we've agreed to aggregate ratings across our core services. So because, for example, if you have two out of 8 core services being of requires improvement will mean the overall rating for, say, safety will be requires improvement. That's an aggregation that doesn't happen in, for example, adult social care. So there's an inbuilt factor, and quite rightly, I think, following board discussions, we've said if there are elements of a trust that are requiring improvement, 2 or more, then we are willing to say that overall that trust requires improvement on that key question. So I think we need to bear that in mind, and we'll bring a paper back in 2 boards' time that develops the thinking more on that, but it's worth saying that. On intelligent monitoring, I think you're quite right, Lewis, to point out the the positives, that where we think there's a problem, there tends to be a problem. But I think it's very important that we say intelligent monitoring doesn't talk about good. It isn't a judgment, and really important, it doesn't look for positive outliers. We separately flag that in data reports and data packs so that our inspectors are briefed on where we see particularly good performance on the data. But as far as the bandings go, there is nothing to, if you do particularly well on staff survey, it will not flag as a positive. It is only flagging the negative concern. So we should not see it as the absence of a significant problem on one indicator or a number of indicators doesn't mean we are therefore saying it is good. We are saying that we haven't from the data spotted any particular issues or sufficient number of issues to put it into one of the higher bands. So it is a difference. The language of false negative, I think, is one of the things we really need to look at, because I wouldn't want to imply that being in band 4, 5 or 6 is any sort of judgment on quality. That's what we use inspection for. It's to highlight whether there is obvious example of concern from the data.
Can I just add to that? It is why we need to inspect. It's as simple as that.
Thanks. So, slightly different point. I mean, I think I'm going to say something which is quite different to what Lewis is saying in a way, which is that I appreciate particularly appreciate the exec summary and the focus on a few small issues and not all of the details. A difference in approach, perhaps, at the board, which you're going to have to square in the way that you ultimately present this. Anyway, I just put that on the table. In the exec summary, you did focus. I mean, I felt then, having read the detail of the pack, on the few issues which it's really helpful to kind of talk about in a bit more detail. And you've covered most of those, David, in your opening remarks, except for the one which is about this thing I don't quite understand, and I'd like a bit more information about, which relates to the material on page 21 of the slide pack, which is that although we seem to have less people in each sector, less institutions in each sector who are failing to meet the standards, non-compliant, we have a larger number of people across all the sectors who are in that position for in excess of a year. And I just wondered if you could talk about what's going on there, because that in excess of a year I find quite troubling, because in principle, looking at this from the patient or user perspective, the fact that we have known for in excess of a year that someone is non-compliant and that they remain non-compliant and that we're not moving them through the system suggests that where there were risks, they are just continuing and we're not doing our job properly. So that's very simplistic, but I'd like to understand a bit more what you think is happening in this space across all the sectors.
So I think you're right to pull this out, and my apologies for not pulling it out in my introductory comments. I don't think I can be definitive about what's happening. I can offer you views about what's happening, but it is something we need to bottom for exactly the reasons that you said, Anna. And I think special measures in adult social care in particular, because this is where this has grown more than in other areas, is of a help here. And we had a discussion at the executive team this week about what is special measures. Special measures in healthcare, hospitals, acute hospitals, is you will get help to get better. And that help will come from monitoring the TDA. And people are receiving considerable resources to get better. In adult social care, you're not getting help to get better. It's putting a time limit round how long you've got to get better. And I think this will then bring us into a position where we need to be clearer about our decisions, about this is the point past which nobody can go. It's a point of no return, of which, to go back, we need to take firm and clear action, enforcement action, which is likely to remove to either changing the registration requirements, or indeed some of these homes are going to have to, or some of these services, sorry, are going to have to close. I think that's the bottom line. So So I think the strategic intervention here to make this better, to improve this, is going to be around the impact of special measures. Now, whether that's aptly named, because I don't know what is the measure that's being taken there. It's a timetable that's saying you've got some time to improve yourself, but after that time has expired, we will take action.
So I welcome that kind of honesty that we don't kind of quite know. I guess what I would like to ask is that in the next 2 or 3 months that you give us a bit more kind of line and length on exactly this set of providers. And I'm reminded here of a conversation that we had around the board table about 18 months ago, I think, about registered managers in the social care sector, where we had that kind of more detailed conversation about registered managers and the fact that so many had not had them for so long, and I think kind of agreed very clearly a position at the board that we wanted that particular issue to be dealt with, and a proposal for how it could be dealt with. So kind of identifying what the themes are amongst these groups in terms of why they are staying on for as long as they are, and then the course of action that we might take in a small number of those thematic areas, I think will be really important. So I don't know what the timetable is, David, but some reassurance that we could take that detail at some point quite soon would be great.
So just on that, David, Robert wants to come in, but what I don't want to do is speculate if I think it might be this or my intuition is this. I think we need to do that work. But what is also clear, I can't remember what paragraph it's in, Anna, but in the covering report, we are reporting that enforcement action is up. So enforcement action as a proportion of all of our activity is up from around 4% to about 6%. So we, in the Chief Exec's report, I report on the publication of the enforcement policy. At the beginning of the report on the academy, the number of our staff going through the enforcement training. So I do expect that new policy that you agreed and we published in the past 4 weeks, and that training for our inspectors to begin to see an increase in our enforcement activity, both in real terms but also proportionate to the number of inspections that we are undertaking, and that should make a contribution to those services which have had outstanding actions for more than a year. Because of the numbers, I don't think our enforcement action will be great enough at the minute to actually deal with all of those that have been over 12 months, and that's why I think we'll do the work that you're suggesting and we'll bring something back that says this is what we think this is, and this is how we think we should tackle it.
Okay, just on the last point, I mean, obviously we can't speculate, but I think it's also the case that actually it's not a sort of bad news thing. It could potentially be a good news thing if we are kind of, our inspections are more in depth, but if we are actually tackling some sort of long-standing, deep-rooted problems, then taking more time to sort them out is not necessarily a bad thing. You know, what I wouldn't particularly want is to sort of artificially, you know, because we need to prove something or other, that we artificially say something's improved when we're not confident about it. I'm not saying we would do that, but I think that there's also the option that the reason people are staying in with issues is because we're actually tackling some of the more kind of serious issues that there aren't quick fixes about. So I think, you know, obviously when we start to look at the sort of ins and outs of what all this means, I think that's something that we kind of should look at as well.
I agree.
And the other thing I was going to say about this performance report, I actually agree with Lewis, actually. I think that, as it is, I think it's very good. And I actually like getting all this detail. And I think it, you know, as NEDs, we should be able to read this and pull out the strategic issues, you know. And I think, in a way, Anna proves the point, because we've got all this data, so we read it and we come to judgments, and the exec pull out issues, but they didn't pull out this last issue about the changes of you know, compliant, non-compliant. So we might not have been able to pull that out if we didn't have all this data, you know. And I think as NEDs, you know, we should be able to read all this and pick out what the salient issues are, compare that with what the exec has pulled out. You know, what we shouldn't do is get into the sort of nitty-gritty, you know, what does this mean and all the sort of details, but actually to pull out some of the strategic issues. So whilst I think, you know, there probably are changes that need to be made, I actually think that we should have all this detail and we should be able to read it and we should be able to come to some sort of judgments and questions about it as NEDs, actually.
I think it's the frequency of some of it, I think. I mean, for example, the relationship between intelligent monitoring and the inspection results is something that we might look at once or twice a year, for example, rather than on a month, whereas some of the financial stuff we might want to look at on a monthly basis. It's just, so I tell you, I take your point, yeah. Paul, then Robert.
So we can definitely circulate more analysis specifically on non-compliance because we've done some of it already from the work that Omar Idris and his team. Omar was on a secondment to us from the Department of Health, recently went back, but he's really helped us on intelligence, and it's worth saying that. The fundamental question is, are they non-compliant on the same thing or different things? And what we find that if you take a snapshot, they tend to be non-compliant on roughly one thing. Sometimes a bit more, but basically one thing. But if you look over the full time they've been non-compliant in an adult social care environment, they've been non-compliant on usually about 9 different things. Hospitals, 8 different things. PMS between 4 or 5 different things. And although staffing is quite a common occurrence, it's by no means the regulation that's most frequently non-compliant. So we can circulate the underpinning analysis, but I think we've got an increasingly good handle. And David's point about special measures and the ability to now rate as inadequate and put a sort of time limit on how long these things can continue is absolutely fundamental to how we shift the picture on long-term non-compliance.
Agreeing as we expected to with comments that others have made, it may be a presentational issue, it may be more fundamental, but we get this stuff which seems to me to be potentially relating to safety, the non-compliance issue over a period of time, but it may relate to other things. It may relate to inaction or by other people, or it may relate to a need for us to focus more on what's happening. And I'm not, the impression inadvertently, I think, may be given by this page, is that we sit a little bit as spectators of something rather than doing our job as regulators of stopping this happening. Because if we define something as being in this category, then we are saying it's unacceptable and something ought to be done about it. We are not the doers, but at the same time we have powers to ensure that things are done. And I'm not sure the information we're getting here enables us to focus on what it is we as an organisation can be doing to correct what looks like a deficiency. It may not be a deficiency because there may be good explanations, but I don't think we're getting that coming through this table. And as it sits here, it means we as non-executive directors are just spectating a persistent non-compliance with people ignoring what we do, what we're saying. And that is a rather damaging message to allow out to those we regulate, because they might begin to shrug their shoulders and say, well, if they say it's inadequate, well, so what? And I don't think that's probably what they do think, and I don't think it's what we intend, but I think we perhaps ought to think that through a little.
I think that's why I made the comment I did about the enforcement policy and taking action, and we are increasing our proportion of enforcement action, and it's for exactly that messaging. And I think this also speaks to Lewis's point about signalling what we're finding from these inspections in a more public way. And there's a sub-theme to this conversation, which is about how we report this and how we draw it out. So let us do more analysis in the next time we report this, so we don't feel like you're commentating and observing something. And I think the analysis that Paul has just shared with us that we've undertaken can actually, I think, play to the point that Anna was asking for about more detail in this, but not just to explain what we think is going on here, to do what I think you're encouraging us to do, Robert, to say, well, so what are you going to do about this? Because that is our job, to do something about this, not to say why it's like this, but is to say why it's like this, and what we're going to do about it is why we're here. And if we don't do that, then we can't answer that question about why we're here, and we do need to answer that question.
Thank you. Just a couple of things. The first thing is just on this point, and that is, when we find poor care, what in total is what I call the effector mechanism for change? There could be a long list of which our actions is just a small part, but for common patterns, it might be worth mapping out. I don't know, Mike. What are the common kind of threads and our role? Because it could be that if we see patterns like this, we end up just ratcheting up the force. But actually, the real effector mechanism is not us. And to get a clearer line of sight on some of those, I think would be quite helpful. And it made me think about this with respect to the special measures discussion we've had on the email about the impact that the KEO, just to be clearer about that and our role, because otherwise we might take on so much on ourselves that, look, these people aren't improving and we're getting tougher and we're still not improving, but actually it's a whole load of other things that we need to be minded of. And no, we don't do anything about those other things, but except to maybe point out and to stimulate those who are responsible for all the issues. Anyway, it's just a thought. So that's one thing. And my other point was just a smaller point, which is on slide 9, and that's the VFM point about our own VFM. So I thought that was a really interesting table on the bottom left on the estimated direct costs of our inspections to us, albeit that some support costs are not included, and that could increase those costs by sector. But I was particularly interested in the relative high cost. I was quite surprised by the cost of community services being as high as they were relative, for example, to NHS acute trusts. And also with a mind on the confidential paper we've got on the confidential part of the board, which is the fee structure, that the difference in fees, discrepancy between our direct costs and the fees seemed to be quite high in community services, higher than the other sectors. So I just wondered what was driving that seemingly rather high cost, and could be as high as $250,000, which seemed rather a lot.
There's actually quite a simple answer to that, which is it's the multiple number of locations that we have to get to inspect, and therefore the size of team we need, the travel around a large patch, and it's why both mental health and community services are more expensive than the NHS acute services, although the actual financial turnover of an acute trust may be much larger. They are much more compact. Usually they're maximum of about 3 sites, and so we can complete the inspection quicker and in general with a more compact team. So I think it just reflects the nature of the services.
Thank you. So the only supplementary is whether we think that is really proportionate considering the risk that we find in that sector.
I think all of these things will need to be reviewed. You are right. If you look at the community health services on their own, they tend to be very much clustered in the good and requires improvement categories, and we haven't had any that as yet are anywhere near to inadequate. So, but I think we couldn't tell that till we'd done it. Yeah. And so I think, again, it's a bit like my answer to Lewis. We're now getting to the number of community health services where we can start putting our thinking together from a significant number of those trusts.
Yeah, just a couple of points, thank you. I agree with others. I think this is a tremendous improvement on where we were 18 months ago. I think we should sort of mark that. This is just so much better and so much richer than what we had. And I really welcome that detail, and I'm quite happy to go on looking at it for the reasons stated. Just on the value for money point, just building up what Jennifer said, I mean, it seems to me that we can't really do much with these numbers until we apportion overhead, and I can't understand why we haven't already done that, because it's not that, we just have to do it, really. There's no kind of right or wrong way to do that. You just have to do it. And until we do that, we can't actually, I think we just need to do that, because there's a lot that will flow from that once we've done it. And just in terms of, I other things that we might like to see. I mean, I suppose the only other thing that I feel is that we're quite good in these papers at explaining underspend. We're sometimes less forensic about overspend, and there are, I mean, it's all in here, but I think it might be worth, there are a number of overspend in the tables which look to me as if they may be going to persist. And I think it's those ones that maybe the next time round we just need a page just going through that. Because if there are overspend in areas that are clearly going to persist and we need to change the budget accordingly, we kind of need to look at that properly rather than just sort of broken out into different sections.
Ask, would people like high-level financial numbers on a monthly basis?
Yes.
Yeah. Okay. We'll do that rather than a quarterly basis. Yeah. But the detail in the quarterly. But
well, I mean, especially if you're already doing it. I mean, I don't think the board doesn't want to kind of create enormous amounts of more work. But if the executive team is already getting it, I would have thought most of us are happy to.
No, well, we'll do that. It's easy to do. I prefer that personally. Yeah.
Sorry, I don't want to delay, but if we just go to the value for money slide, what I think it's worth noting in relation to that, it's quite a one-dimensional snapshot of the value for money that CQC delivers, because it's looking at the costs of inspection. And the work that we're doing on the value and impact of CQC is looking at the other things that we do under the functions as our regulator. And that's why this is at very early stages, and why it's actually not especially helpful to apportion overhead at this stage, because there are many other things that we need to apportion overhead to, which sit under what CQC does as a regulator. And I think increasingly we need to think about the value that CQC delivers beyond inspection. That's one element of what we do, but it is not the only thing.
It's within our sort of inspections, we are, in our role, we're saying that we it's important that we recognise good care, outstanding care. And I just sort of think, looking at this performance report, inevitably we focus on the things that we're worried about or the problems. But actually I think, if we want to sort of practice what we preach, as a board, we also need to make it clear that actually there's some really good stuff in here. For example, we've got some outstandings, lots of goods. So registration, the contact centre, mental health act visits. So I think it's just important that we kind of live those values as well, because and not forget that, because there are some really, some really good stuff in here, and not, to give the impression that we're focusing too much on the negative, but actually recognise that there is some really good stuff happening as well as we would in our inspections. Yeah.
Thanks, Kay. Right, thanks very much. Next item. Committee terms of reference. I hope we're pretty much there with them. That may be tempting fate. Is everyone happy with the terms of reference of the three main board subcommittees? Yeah? Yeah.
Yesterday, we had a regulatory governance committee meeting, and I think we all felt that the activities within there were the right ones. But we also felt there was quite a lot in there, and we only meet every other month for 2 hours. And what we've spent some time as a committee is sort of working out how best to do the job. And I think we've come to actually quite a good way of doing it. But what I was going to suggest, that in the actual terms of reference, there could be, because it gives the impression that we're going to do all of the things in the list. But I think what we perhaps need to put in is that it's for the committee to determine the best way to discharge its responsibilities. So it's up to the committee to decide how best to do what it's tasked to do. So we've developed a way of working, but what it isn't is going through all the list of activities. What we've come up with is, I think, a very good, sensible, practical model. But just something in there about the
discretion.
It's not just a work plan. It's how we discharge our duties so that we meet our responsibilities. In the best way that we can from a sort of governance perspective. Yeah. So I mean, it's partly work plan, but it's also us having, deciding how we're going to do the job in the most effective way. It's for us to kind of determine that. Yeah.
Yeah, just picking up what Kay was saying. I think when we looked at item 3, responsibilities within the RGC, and Michael might like to comment on this, there was a long list of bullet points in there, and essentially they could be interpreted as the committee will look at each and every one of those. They're not responsibilities to look at each and every one of those, but amongst those things might be the things which inform what the real responsibility is, which is actually described in the role and scope above. So it's a few words at the top of that, I think, just to make that clear. And I think that's what we agreed in the committee.
Have you got that, Sandy? Yeah. Thank you. Yeah, commitment.
Can I make one other tiny point, which we discussed at RGC as well, which is just the same thing about flexibility. And it's absolutely right that we have quorum. That's very important to define. When we have the number of people who need to be in attendance, I think we need to be a bit careful that this doesn't end up becoming, you know, a way of sort of forcing enormous numbers of staff to attend all meetings. We're in danger of having more staff than non-execs at some of these meetings. So again, would you maybe just give ourselves a bit more flexibility there? Because there will be times when we need certain people, but there will be times when we don't.
Right, thanks very much for that. Now, the Declaration of Interest policies. Firstly, Sandy, thank you very much for doing a very comprehensive paper on this. A number of notices have raised issues with me about the that it's so comprehensive that it's how practicable it is to comply with it, and this is an issue, and I think my suggestion for handling this, I think this needs to be a public document, clearly, is that we need to have one more crack at it between now and the next meeting, which I'd like to do, if people are happy to do that. People happy to do that? Yeah? Good. So we'll bring it back to the next meeting if we can, Sandy. Thank you. Paul, ACG report, did you want to say anything?
No, I think the short notes that summarises what we looked at there, I'm happy to take any questions on that.
No. Good. Any other business? No. David, you're still here. You said you were leaving, but...
I didn't think you finished quite...
No, it's not really, but...
Well, I did have two questions. One is, we have discussed low pay or the possibility of the Low Pay Commission, talking to the Low Pay Commission. I'd like to raise again this question of inspecting local authorities, because behind the low pay which people get from care providers is the fact that they get so little from the local authorities. You used to do this. It would be a very good thing, I think, that if you were to start it again, and I wonder what the board's view about that would be. It's noticeable that the Sunday Telegraph, their campaign on justice for the elderly, that is one of the things that they are suggesting. And the second thing is, looking at the strategic risk register, I did not see anything about the risk that the mums test might be forgotten, and I wonder whether that could be added as an additional risk that the mums test might be forgotten, and some mitigation of that should be also provided.
David, do you want to do the first question then?
So there's been episodically during this Parliament, which is now coming to an end, a debate about whether our powers should be extended to include oversight of commissioning. Norman Lamb, the Care Services Minister, has raised this on numerous occasions. I think the top and bottom of this is that we do not have the power to regulate or inspect commissioning services. We have the opportunity to comment on those services where through our regulatory activity we can see the consequences, but we don't. Just in a very simple way, David, we don't have the power to do that. Parliament can, if it so chooses, decree that we are given that power, and then we'll have to have a conversation about how can we do that. My personal view at the minute is that, and if the last discussion on the performance report doesn't make this point. We've got more than enough to do to actually do what it is that we've got to do before we start reaching into how services are commissioned. But the straight answer to your question, David, is we don't have the power to do that.
Andrew, just on the My Mum's test, slipping off the risk with...
Yes, I mean, I think that we don't specifically mention the mum test, as David says, but we do have a risk, which is that CQC does not listen to the public and stakeholders, respond effectively to the support and advice given, or meaningfully build user voice into our regulatory approaches, which I think goes to some way in actually embedding in both our kind of strategic risk assessment of the things that we need to be doing, and therefore the mitigating actions that we need to take in ensuring that we are embedding our new approach to the way that we inspect and regulate services in such a way that makes the mum test real. And we do that from an adult social care perspective, but actually, we all apply that kind of metric in the sense of, is this a service that we would be happy for a loved one to use across all of our services? It's not original, and it's not unique to CQC. But in the provider handbook that we've written, which sets out for providers what it is that we will do to regulate and inspect services, and therefore what drives our information to inspectors in terms of what we're expecting them to do, it's clearly set out that actually the whole approach is about making the mum test real. So it's there from that perspective, and I think is implicit in the strategic risk that we've already got, David. And I won't let them forget it, just so that you know, David.
Thank you, Chairman. Two questions, if I may. One relates to unexplained deaths. And this data is very clear and held by coroners and their deaneries. Is that data shared with CQC where appropriate? Is it shared as an automatic thing?
I think there's an expectation it is, but I'm not sure it's always shared in a timely way. What we do get is the results of coroner's investigations. But one of the challenges that we absolutely have in regulation is by the time those reports are complete, the event has often happened some time ago. So it's not necessarily a reflection on the current service.
Thank you. The other question relates to inspection of independent hospitals, private hospitals. I believe that currently they're not rated. It's my understanding that virtually all private hospitals now take NHS patients who are outsourced from their another trust. And is there an intention to provide such ratings so that patients will have access to the information that helps them to decide where to receive their treatment?
Simple answer is yes. We will be rating independent hospitals, but in the same way as in our first waves with the acute sector in the NHS, and then with mental health and with community health services, we didn't rate to begin with. We got experience first. We will be rating the independent hospitals.
Is there a timescale?
Yes, there is. If I can...
Yeah, we've just completed the consultation on the draft provider handbook. We'll be aiming to publish that in the next month or so. We'll probably take the opportunity to update all the provider handbooks at the same time with the fundamental standards, for example. Our expectation is that we would start to rate soon after that. What we will want to look at is whether we can rate across all services straight away, or whether, for example, the data on effectiveness would mean we would hold back on rating on effectiveness for perhaps a period of 6 months. But we're still looking into that in light of the consultation.
Very much. Right, I think that concludes the meeting. Coffee, and then we'll resume in 15 minutes if we can. Thank you.